I would like to introduce Dr. Eric Whitaker now as our second speaker. Dr. Whitaker is the Executive Vice President, Strategic Affiliations and Associate Dean of Community-Based Research at the University of Chicago Medical Center. He is responsible for leading the University of Chicago's Urban Health Initiative, linking the medical center's mission of patient care, teaching, and research for the purpose of improving the health of Southside residents. His research interests include HIV/AIDS prevention and minority health. Dr. Whitaker was also previously the director of the Illinois Department of Public Health, so certainly in many arenas of leadership has Dr. Whitaker expanded his concept of partnership. We welcome Dr. Whitaker to share with us his work in Chicago. Thank you.
Good morning. You know, I want to join Tony Preckwinkle and welcome you to our fair city. It seems like you caught us at a good time in the weather cycle. We've had fall and winter and rain all in the last couple weeks. I also want to join Al in applauding Larry Gage on the work that he's done, and also the NAPH for the last 30 years. You know, I've had the opportunity, being a former commissioner of health of a state, I've gotten a lot of awards, and you know, one that I cherish is the one I got from NAPH prior to that time. You know, I along with our team won the Tim Wright Award for some of the work we did with Black Men's Health on the South Side through Community Health Center affiliated with Cook County Hospital. So you know, it's good to be back before you. I work at the University of Chicago, but really I'm a county hospital type of guy, having trained at San Francisco General Hospital and spent 7 or 8 years at Cook County Hospital before becoming a state health commissioner. So ended up coming back to the University of Chicago and trying to take us in some new directions as an institution. And what I'm going to share with you is a grand experiment, the end of which I don't know yet. You know, I'm not quite sure how this story is going to end, whether or not it's going to be a tearjerker or if it's going to be a horror flick, or exactly how this thing is going to end. But you know, I can tell you that at this point, you know, I've been at U of C for about 3 years, and I like the directionality of how things are headed. In fact, we had an Urban Health Initiative Summit yesterday at one of the mega churches on Chicago's South Side, and you know, I have to tell you the energy, the commitment of the people in the room. We had somewhere in the neighborhood of 120 community-based organizations, a lot of political leadership, all folks who were trying to think about not only how to partner in terms of health care, but how do we improve health? And in fact, you know, one of the biggest issues that arose is how do we deal with economic development as a part of the mix of how we improve health on the South Side of Chicago. And this story that I'm telling you is a story about partnership. And so first of all, this is how the University of Chicago likes to see itself. You know, it looks pretty tranquil, doesn't it? You feel kind of good looking at it. You know, the fact of the matter is that if you go south of there, you know, for a lot of history's time, the university really paid no attention to the community, and there's a great deal of distrust with the community. In fact, my grandparents lived outside of this photo to the bottom, and when I was accepted to medical school at University of Chicago, they told me not to go because of the antipathy between the community and the university. In fact, when I first started at the University of Chicago, I would ask our audiences, how many of you all are skeptical about the University of Chicago? And I would raise my hand. And my boss would say, you can't do that. and I told him that, you know, if I'm being real, you know, I'm skeptical about what we're trying to do, though I've come a long way towards feeling like we have a commitment and we're trying to actually move things forward. So, you know, this is how people in the community look at the University of Chicago, which is very different. Really, you know, a castle with a moat around it and the drawbridge tightly wound up. So this whole idea of partnership has been historically a foreign one. In fact, you know, as we think about research, education, and patient care, I mean, we literally did not go off our campus. We stayed on our little island and didn't go off the campus. In fact, you know, I remember the first day of medical school, they told us not to go across that that southern border. And again, my grandparents lived across the street, and I'm raised my hand and like, you know, what's up with that? So, you know, we had to really have a reorientation about, you know, what it is we're doing. So through the Urban Health Initiative, we've along with our community, taken ownership of 34 community areas out of 77 in Chicago, which we call the South Side. And as you can see, this is a dot that demonstrates where the university sits. It's surrounded, these dark areas. This is a map that shows the percentage of families in a community that has an income less than $25,000. And the darkest circles is about 50% to 65% of that community would have less than a $25,000 income. And as you can see, it encircles the University of Chicago. So, you know, this is an area that has a lot of poverty, has a lot of need, you know, healthcare needs, health needs. Unemployment is rampant. You know, a lot of the social challenges that one might have in an urban community. And so what we've tried to do is establish as a mission for the Urban Health Initiative a model to optimize and sustain health in what is a very resource-constrained urban area. And our vision, which, you know, just yesterday I talked about the Urban Health Initiative Summit, we reaffirmed with our communities that we want to have a model of urban health in the country by 2025. And, and we reaffirmed it as a group because people often talk about Dr. Whitaker's vision of the South Side. And I'm like, no, this is our vision. And we all have to be engaged in this. Though I have to admit, someone yesterday asked, why wait till 2025? And I had told him, you know, that what I didn't say is the fact that I started out at 2015 when I got there, and we've had so many leadership changes. Every time I got a new boss, I would add 5 years. So, I mean, literally, I started on October 1st, 2007, and every October 1st, I've had a different boss. So I think we have the guy that's going to be there for a while, and you know, we're going to do this over a time period. But it's important to me that the university had a commitment to the date more than anything. You know, our goals are to, you know, develop trust. You know, because again, there's a lot of skepticism about the university. Really create a system of care where one didn't exist at all previously. And we are an academic institution and want to produce academic leaders in population health that are expert in urban health. Now, you know, we are trying to take the academic model and shape it in a way that service has a place at the table in a way that it historically doesn't. And so, you know, we are working on research because we're a research institution and want to leverage that data to make an impact. And so we work on, you know, how do we change the delivery system in a way that works. In fact, started something, you know, this was done under Michelle Obama maybe 6 or 7 years ago. She started something called the Southside Health Collaborative, which at that time was 18 community health centers working together to try and find a medical home for the 40% of our emergency room patients who didn't have a regular doctor. And since, you know, I came on board, I've expanded that. It now has 35 community health centers, private physicians, 5 hospitals, and some private physicians, and we all sit around the table and think about how to improve quality across the system in partnership. Now, you know, it's no easy task getting these folks who normally are competitors sitting around a table, and in fact, you know, I remember the first meeting I came to, I said, we're going to create an agenda. Everybody said, okay. Next meeting, no one wanted to do anything. The third meeting, I came with an agenda, and they were like, what are you doing? And I said, look, I have an agenda if you don't have an agenda. And then the fourth meeting, everyone started working together, and over time, we developed the trust that we need. We also are developing the basic science for what we need to drive change. You know, really, as you know, a lot of the public health data that exists is at a county level, and that, you know, in a city as large as Chicago and a county as large as Cook, that's not meaningful for what we're doing. So we basically are creating our own public health surveillance for the South Side of Chicago that's granular and it gets fed back to the community to help set priorities. And lastly, in terms of the so what of our research, we use the Center for Community Health and Vitality as an entity to translate that data into meaningful programs that exist on the South Side. Because that was always the challenge for me when I worked in the community at county. I couldn't find data that I needed for needs assessments, for grants, or for program development. We now curate data. Any research done on the South Side of Chicago, we collect it, and it's available, and we help our partners in the community use that data for their own purposes. And the result of all of, and I should also say the center takes more of a public health approach and worries about economic development, education, and things beyond the healthcare system. It's an overall approach to care. It wouldn't surprise you we're an academic health center. It heavily leans on the mission of an academic health center in terms of patient care, research, and education. In terms of partnership, we have to partner if we're to be successful, and have done so through the collaborative and all of the federally qualified health centers and hospitals. We have a robust relationship where we now have 2 services at Mercy Hospital staffed by University of Chicago doctors. And again, we didn't used to go off of our little plot of land, and now we have a robust relationship there. At Access Grand Boulevard, we now partner with this federally qualified health center that is the largest network of FQHCs in the country. And we have a center where there's 14 different medical subspecialties that we have that are there. Provident, which is part of the county system, I would love to do something there. They're in the midst of their strategic planning, and we've been planning alongside of them. There are a lot of political challenges, but my fervent hope is that we can someday come to a conclusion about what we might do with that public hospital on the South Side. And lastly, we have a robust patient advocate system that helps our South Side patients navigate this complex system. As Al has mentioned in New York, we in a similar fashion continue to work towards having interconnectedness using electronic health records. And this just gives you a sense of the partners that, again, we've just formed in the last five plus years. Research is incredibly important because, as we get funders, they want to know, are we getting value for the dollars that they invest? But important in our paradigm, our interests aren't driven by investigator-initiated research, but really by the community and what its priorities are. And the Center for Community Health and Vitality is a major part of how that gets done. Surprisingly, research findings get shared with the community who participate in the research. And there has to be community benefit in the research we do, or we shouldn't be doing it. At least that's my approach. And I just want to give you a sense of what has been a game-changing project for us, which is a community asset mapping project. One of the things that's true on the South Side, and I'm sure it's true in a lot of the communities you're in, there's distrust of research, and people start talking about Tuskegee and other things, other challenges around research. And we ended up, we look at the South Side not from a deficit model where we talk about, and this is bad English, what we ain't got, and we think about what we do have. And so, we ended up really trying to figure out what assets do we have so we can build upon them. And we have teams of people who walk the streets to figure out every grocery store, every park, every building, every church. And that's a physical building mapping. We're in the midst of doing service mapping now so that when we look at that church, we can find out if there's an adult day health center there, is there a food pantry, what exactly is in that entity. And this has been a powerful tool because, say with some of the aldermen in our community, they were skeptical about research. Now they see this research and the data that gets generated as a tool they can use to advocate for what they need in their communities. So one of the biggest opponents of our doing this work, Alderman Cochran, he talked about Tuskegee and the University of Chicago. Now he's telling us we're not working fast enough because he can see how the data is helpful for him advocating for things he needs. Another alderman used this data to advocate for a Walmart in his district, which, you know, I don't want to get into the politics of Walmart, but you know, he was able to go up on a free website, find data for his specific area, and use it to make the case. And we're now in our third year. We're in 11 of the 34 communities with an aspiration of expanding through all 34. And you know, this just gives you an article was written about this in 2009 when we had college students and community individuals who were working together to do it. Last summer, we ended up using high school students who actually did it better than the college students. And so we're in the midst of working with Mayor Rahm Emanuel to do this all over the South Side and use it as a summer employment opportunity. These students got to see their communities in ways that they never imagined because there's a lot of assets that people didn't even know existed there. And this ends up going into a database that's on the website, southsidehealth.org, that's free. Though, you know, we end up selling our data to PepsiCo. Our data is better than anything you can get from Dun & Bradstreet's, Google Maps, Yelp. So we have the best data on the south side of Chicago you can find, bar none. And we're trying to monetize that in a way that it helps sustain the project. And this gives one example of a project. You know, again, our community came to us and said, you know, we want to create a Woodlawn Children's Promise Zone akin to the Harlem Children's Promise Zone in New York. They said, so in Woodlawn, where do kids get their medical care? And what we found out is when we did our maps that there was one practitioner who said he dealt with kids. You knock on the door, he doesn't answer the door. So in effect, there's 8 elementary schools in Woodlawn, no pediatrician in the community. And so that ends up making it a priority for our community partners to develop a school-based clinic that'll serve all 8 schools. And then the community came back and said, okay, then where are our kids getting their health care? And so we continue to help them think through and answer that question. They're getting health care all over the city of Chicago. And so now the community is asking questions, and we have the data that can empower them and answer those questions for them. You know, in terms of the education mission, you know, we historically have been subspecialty focused. And I remember when I was going away to public health school, people thought I was absolutely nuts after my 3rd year of medical school there. And we now have a community health track that deals with scholarship and community health, which is a new thing in the last 2 years. We've established an Office of Community-Based Education. In fact, getting our students off campus working in FQHCs and other community-based sites. We also have started a loan repayment program for our specialists as well as our primary care docs who practice in our network, the Southside Healthcare Collaborative, to entice them to stay on the South Side. Historically, people get their degree and they jet out of the community, so we're building capacity by keeping more of our talent at home. And the center, again, the premise is not deficit-based but asset-based, and really is around those 2 missions of research and education. Our community helps conceptualize the research, carry out the research, and interpret the research. And they actually go present papers on their own. They're co-authors on our papers, and it's been, the community, they have their own expertise, and they've been a joy to work with and help us find ways of thinking about things that we historically had not thought about. And also, the community wants us to help with jobs and job training, which we do, and also employment opportunities. We have something called the Community Grand Rounds, which just wrapped up its 7th in a series where we work together with communities, come up with the topics that communities want to hear about, bring community expertise along with some of the academic expertise. You can see the topics that we did to date. In fact, the mental health services one was done in the form of a play, and was so well received that now a local theater company is reproducing the play to be done in this fall as part of their normal series. So they're talking about mental health, a topic that's tough to talk about, and it's being received in a way that people can receive it. But all of these issues, again, were issues that the community themselves wanted to hear about. And our community, surprisingly or not, it really is interested in technology as a way to improve health. And we are working on on a research and development model where community comes in as full partners in helping us assess and think up ideas that can improve their health, with technology being an important part of it. We have the expertise, both community and university. We have a lot of need, and we have a world-class institution in terms of research. When you tie those things together, there's a lot of innovation that is occurring, and that over time will demonstrate, I believe, impact in terms of health. And as I close out, the principles of partnership really, the critical thing is building relationship and agreeing on a shared mission. Trying to balance power, which is tough. When academic institutions are used to being in control. And lastly, have an open and accessible community. I'd like to think the team that I brought together have helped foster this, and that it's slowly becoming institutionalized. Though we know institutions are institutions for reasons, and we're going to continue to move forward. And again, none of this would be possible without partnership. So I hope I can come back in the next 5 years to tell you the end of this story, as it's yet still being written. So thank you for your time and attention. I look forward to the questions.
Certainly a rich portfolio of work, Dr. Whitaker, and congratulations on all that pioneering work you've done out there. So we just have a few minutes for some questions from the floor. Would there be anything out there? Yes, Bruce, thank you.
Can you all hear me? Great. This is primarily a question for Al, but Eric may want to answer it also. So given all the things that have happened at HHC, growth of Metro Plus, the growth of community physician relationships, the talk, the idea of pilot ACO, what are the implications of that for the academic affiliations that also sit within HHC or a part of it with the medical schools and the like? Because one of the big themes we've had here is sort of physician, medical school, health system alignment. What do you see as the implications for that for you all?
Well, we have a long history of, as you know, Bruce, affiliation relationships with virtually every medical school in the city, and it is somewhat unique in that it's not just an academic relationship. They actually employed our physicians, so it's a service delivery relationship as well. And we are in the process of fundamentally altering that and have actually ended the service delivery component for many of those relationships, in part because we feel we need a more unified physician workforce and a more nimble one that can actually partner with us closely in terms of the adaptive capacity the organization has to have going forward. And negotiating with 8 different sets of clinical leadership was, we managed to do it, but it took forever. So that's one issue. The other issue is engaging with academic medical centers about how to rethink their model to some extent, because it does introduce an awful lot of inefficiency into the delivery of those services, and it bumps up against patient-centered care often because of the residents going in and out. There are ways to deal with that, but it does require, I think, the academic medical centers to be partners in terms of restructuring how some of that plays out.
Dr. Whitaker, you want to respond to that question as well?
We're in a different situation in that we're the only game in town on the south side of Chicago, and I don't know if anyone really wants to be in our game. We have a lot of challenges in terms of payer mix and the like on the south side, and a lot of what we're trying to do is to, again, work with the assets we have on the south side of Chicago. You heard Tony Preckwinkle mention about a strategic plan for the county system, and they have a vision at the Providence site that I talked about of having a subspecialty, a regional outpatient center. But the fact of the matter is they don't have enough subspecialists to even carry out that vision, at least in that site. I don't know about anywhere else. And that's where a partnership with us will be very, very important, I believe, and if we can get around the politics and the like to make it happen. But something will have to happen like that to get anywhere near what we need for healthcare reform.
Another question from the floor. Larry.
Yes, thank you both. Excellent presentations. I think we all know the song that starts, the south side of Chicago is the baddest part of town.
Leroy Brown?
Bad Leroy Brown, you all know that? Jim Croce. But I think in both cases, and I think it's true with many of the systems around the room here, you've experienced two different kinds of demographic shifts in many of the catchment areas of your facilities. Gentrification, and then also a demographic shift from one type of population to another, from African American to Latino, or in some cases to other ethnic groups. And I guess it's sort of a two-part question. What does the gentrification mean to hospitals like University Hospital or Harlem Hospital Center? And secondly, what do you do to follow the patients who are crowded out by gentrification? And third, what steps have you taken to address the demographic changes even within the lower income population groups in your respective parts of the cities?
Can you ask an easier question, Larry?
I only have about 5 more minutes.
So, I mean, part of the strategy for us, HHC, is that we have the benefit of having invested $1.5 billion in construction in our facilities. They are very competitive from the standpoint of physical infrastructure. We now can demonstrate objective quality measures that compete very well with the voluntary system. We do need to expand our payer mix so that these new populations coming into our catchment areas use us as well and help us with some of the cross-subsidy that's needed for us to sustain our mission. It is an incredibly heavy lift in a city that has so many hospitals and so many designer brands. No matter how good you are objectively, everybody wants to be middle class, and unfortunately still public hospital doesn't equate with middle class. So that's a very, very stiff headwind. So we continue, and we're not prepared to adjust or sacrifice the mission in any significant way. So that is going to be a major challenge going forward. We're determined to make headway. We do slowly make headway, but we need to accelerate that.
And I would say, we actually have not seen as much gentrification as one might have thought. The areas I talked about, the 34 community areas, 77% African American that suffered from hypersegregation previously. So they really, it remains stubbornly African American. For better or for worse, I'm African American, and things have not changed as much. A little bit on the margin on the north end of our service area, but really the populations we've been seeing historically are the same ones we see now.
Perhaps time just for one more question from the floor, if there's anyone. Right over there, Melissa.
Melissa Stafford-Jones, California Association of Public Hospitals and Health Systems. Thank you for your presentations. I wonder if you could comment on the issue of clearly partnerships and a lot of linkages and work with many organizations in the community is critical to not only improving healthcare, but the health of the populations you're working on. I wonder if you could comment on the actual role that you see for public hospital systems in that work going forward. At what point does the service delivery work become public health work? Sort of where is that gray zone, and how far out should we be thinking about pressing that role, that mission, that proactive work that public hospital systems could be doing to really work on health and not just healthcare?
I think it's hard to do that at full scale until we actually hit a tipping point in redesign of the reimbursement system, right? Because you need to be able to deal with this from the perspective of a pool of dollars that can be wisely invested with front-end investments that don't necessarily have to be the conventional front-end investments that can take into consideration some of the cost of bringing these other players to bear who can add value. But it does require you being pretty rigorous in the analysis of what's cost-effective and what's not at the end of the day. And unfortunately, we're still a ways from that point.
I don't know if I have anything to add to it.
Well, thank you. Great session. And Let's have a round of applause for our presenters.
Thank you very much to Winston, to Al, to Eric. Great presentation and a great way to start off the morning. We have our next set of panelists coming up, and now we're going to, in some ways, sort of leave the on the ground and maybe move to about 10,000-foot high level and talk about the response to reform and see that perspective from really two national experts in the area, two folks who probably have maybe better perspectives than just about anyone else on these issues.